Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Kahlid Baig. Dr. Baig practices family medicine and is on staff at Washington Hospital. Dr. Baig attended medical school at Osmania Medical College in India. He conducted his internship at Albert Einstein University in New York and his residency at the Catholic Medical Center in New York. Dr. Baig is board certified in family practice.
Ms. Kim asked me to present understanding labs to improve diabetes management. I jumped at it because that's right up my alley. I love this, lab component in diabetes. The reason being, if you look at diabetes, there's a defined number compared to other conditions where it's very difficult to know where a person is going. So we have an advantage in diabetes, and that is we can look at defined numbers and parameters and take advantage of that. So I would urge you to stop me anytime and ask me any question you want. What I'm trying to do here is give you that knowledge that when you go back to your physician, you are able to understand what's in the background. What do I need to know as somebody who has diabetes, or even, my relatives or friends, whoever, and be able to give that information and take the important knowledge from it to improve outcomes. So our goal is basically to be able to manage diabetes well. In other words, before we started with diabetes, we had a normal metabolism. So how can we get back as much as possible? And that's allowable for the majority of us, but there are some exceptions, as we can see. So what I've also done is I've introduced a few other things here. So it's like filling, when you get a big package, you have a little filling. So please excuse me for that. But that's to enhance knowledge. It's not to fill up the talk. So I'm hoping it's going to tie up with what we want to do here. So just as a little understanding, if you notice here, the reason we are very concerned about the United States is because 30% of our adolescents and children are obese. Obese means a body mass index of more than 30%. So that is very, very significant, and we want to be careful how we look at this. And the second important part with diabetes is it's shown that once a person starts developing pre-diabetes, it takes them anywhere from 10 to 20 years to develop that. And this is where we're seeing a big majority of diabetes come in, mostly in the southern, eastern part of the United States. And if you look at California, it looks like California is spared in many areas, but it's really not. We're seeing a big jump in diabetes here. And again, if you look at the age-adjusted incidence, now incidence means increase in diabetes. Again, you're going to see California is coming up very well on that, and that's not a good sign for us. Lastly, if you look at the number of people diagnosed since 1980 up to 2009, there's a 3 times jump in that incident. That's huge, and it's going up more. If you look at the WHO statistics, India and China now take the lead in the world, but guess which country is third after India and China? in the world for developing diabetes. U.S., absolutely. Absolutely. That's scary. That's scary for us. It's not Europe. I hate to say that, but we need to do more for us. So just very briefly, diabetes is divided into type 1 and type 2. I'm sure we know that, but the reason it's important is type 1 has a different set of challenges and type 2 has a different set of challenges. And we're going to be talking mostly on type 2. I'm sure everybody knows about hemoglobin A1C. If somebody doesn't, please raise your hand. So I'm glad we all know about it. So what happens is in our blood, we have hemoglobin, which is the carrier for oxygen. It's a protein which carries oxygen. Now, what we've noted, luckily, many years ago, this is more than 50 years ago, was the fact that there's this special type of hemoglobin or protein called hemoglobin A1C. And as the blood sugar levels increase, hemoglobin A1C rises. And if it decreases, it goes down. Now, there's another interesting component to hemoglobin A1C, and that is it takes 3 months to make a change. And if you look at the research on hemoglobin A1C, the last 2 months are the most critical ones in shaping the final number, whatever it may be. And the third month is not as critical. But no matter what it is, it's a great window of what we're doing. In other words, we're snooping into your background to see how you're doing. And that's how we guide ourselves. So this should be a bottom line test. Before, physicians would not order this frequently, but now you're going to see almost every physician do it because that's the norm. We want to know where we are standing. And since I'm a family physician, I see children also. And you will not believe this, but I screen them from age 5 if they have enough risk factors. And as they get older, I do it more frequently. And we're picking up a lot of prediabetes on that. So it's a little scary, but that's how it is. So the bottom line is, we make a diagnosis of diabetes if the hemoglobin A1C is more than 6.5%. That's the magic number. Or the fasting blood sugar is more than 126. Now, it has to be more than 126 on 2 different occasions. So that's the key here. And we also want to make sure we're fasting for 8 to 12 hours. It's so funny because this is my field. I think everybody knows about it, but that's not true. Also, if we are not doing that, then we can do our 2 hours after a meal during a test where you load up with sugar, which is 50 grams. And I just don't want to go into detail, but the point I wanted to make was it's not as simple as we used to think it was before, where we said, we have the pancreas, which are, even though they're producing insulin, we are unable to utilize that insulin in adult onset diabetes, type 2. So there are a number of other hormones which take part in that. And one of the most important ones is muscle and liver. So I just wanted to bring it to our attention. So going ahead, the reason I put this slide earlier is there's a study called UKPDS. Now, this was done in the United Kingdom many years ago. This was done when I was just starting out. And this study was a landmark study. What it showed was, if you looked at the hemoglobin A1C, and for a person with 1% increase, so for somebody who's going from 6.5 to 7.5 or 7.5 to 8.5, they would increase their chances of complications by 12%, which is a significant jump. And that was a landmark study because nobody had looked at this before to see what was the parameters where we would be able to detect not only morbidity, but all the other consequences which come after that. So that's why it's so important, and that's why everybody pays so much attention to hemoglobin A1C, because this study literally brought it in to see where we're going. So, and of course, we increase. In fact, there was a study which just came out today, and what that says is with increased weight and diabetes, the chances of developing mortality is much higher than we thought before. So it all ties into the same thing. I I don't want to criticize over-the-counter test, but you can buy an over-the-counter test in, like, say, Walgreens, which checks your hemoglobin A1C. And even though it may be kind of cheap, but at the same time, accuracy is the key here. As a pathologist, I can tell you, if a test has a variation of more than 11%, I don't think it's very reliable. And we don't know about these tests. So I would urge you to be careful how you judge your hemoglobin A1C. But the major labs, like our lab at Washington Hospital, and or if we use Quest or whatever other lab, the big ones do a great job. Their method of performing hemoglobin A1C is extremely reliable. So I would urge you to keep that in mind. And getting ahead with prediabetes, as you said. So we already talked about it. Prediabetes is when we have a fasting blood sugar of more than 100 to 125 and a hemoglobin A1C of 5.7 to 6.4. It's in your handout. The reason I put this up is once we know we have prediabetes or diabetes, we need to go after it. So how does one go after it? Let me put it this way. If you have a person who has a body mass index, I don't know if everybody's familiar with body mass index. If you're not, I'd be happy to present that. But body mass index is literally based on height, gender, and weight. So if a person is below 25, they are okay. But if somebody is between 25 and 30, then they are considered overweight, and 30 plus is obese, and 40 plus is significantly obese. So there are all these classifications. But we look at the BMI very carefully. That's one of the reasons I put it up here. So I would urge you to make sure when you see your doctor, ask your doctor, what's your BMI? Because you don't want to be creeping up and not knowing about it, because that's where insulin resistance comes in, and that's where the prediabetes gets into diabetes. So these are very, very important. And as you know very well, we are targeting Asian Americans also because they have the highest incidence of increase in diabetes and prediabetes. And other factors, just very briefly, physical inactivity, and if you have a relative with diabetes, and ethnicity also matters a lot. They are very, very critical in having diabetes. The other reason I put this up here is because I do a lot of physical exams in primary care, and one of the most important thing is once a person has diabetes, you want to make sure with your doctor that these are being addressed to the complete extent possible. That is not only to control your diabetes, but to make sure that there are no complications of diabetes which exist. So, and that is age and characteristics at the onset of diabetes, patterns of eating and physical activity, nutritional status, growth and development in children. If they are obese, then of course that needs to be addressed. But my request to you is when you have a physical exam, I would urge you to keep this in mind. So you want to know not only your height and your weight, but your body mass index. And you want to know where your blood pressure stands, because it's very critical. We've learned that in diabetes, you want your blood pressure at the best below 120 by 80. It's not possible for everybody, but that's what we want to aim for. And the new guidelines are if a person is above 55 years of age, it's okay to be below 140 by 80 and not just 120 by 80. But with diabetes, it's a special group. You want to be as close to 120 by 80 as possible. And that goes a long way. Yearly eye exams, very, very critical. You want to make sure the thyroid is not malfunctioning, because people who have hypothyroidism, their diabetes gets worse. So you can have a person who's, out of the blues, their blood sugar starts going up, and then you start thinking, instead of just going up on the medications, one of the most important things to do, make sure that the thyroid is functioning normally. A foot exam is the most critical exam. Now, my question to everybody is, how often do you think you should have your foot examined with your doctor? Yeah, every visit. We want a mirror to look at the bottom of the foot to make sure that there's nothing hiding behind there. And every night, it's a good idea to feel the foot to make sure it looks okay. It feels okay. So these are the important things. We don't want dry skin. The most common problem is dry skin. So we don't want a foot which is dry, because if it cracks, that's the portal of entry for bacteria to come in and cause a foot infection. It's rare, but I just don't think we want to take any chances by being careful. And when we clip nails, we want to be careful how we clip them. So these are all these simple but important things to do. And there's another slide which is coming up, which is very, very critical. I would urge you to take a look at that. I think it should be also in the handout, but we'll look at it again. Okay, monofilament is a little filament which sticks out like that. And when you have a foot exam, it's important that the examiner examines the foot with a monofilament. So this is the lightest touch possible with that filament. And if we lose sensation due to diabetes, because diabetes affects certain fibers, nerve fibers, which are of a certain diameter, these are the first ones to go, and we won't be able to feel that monofilament. You can touch the foot and you can feel it, but with a monofilament you can't feel it. So that's the earliest loss of sensation. So it's called a monofilament test. Very simple, but it needs the filament to be tested. So it's something to remember, and I would definitely urge you to do that. And getting along, how often since we know what hemoglobin A1C is, how often do you think we should be checking our hemoglobin A1C? Twice a year. Thank you. Yeah, but okay, that's a great answer. Nobody's wrong here, but this is the key. If my hemoglobin A1C is out of control, I wouldn't wait for twice a year. I want it done every 3 months, because that's the best window, so that I know where I'm going. And once we're stable, once we're below 7, we're okay. Twice a year is fine. Actually, there's some gentlemen I follow and ladies who are doing great. They do it once a year, and that's fine. But it's critical that we follow that pattern and know where we stand. That's where the hemoglobin A1C is so great. So we monitor blood sugar at, by ourselves, and then we do the hemoglobin A1C. And I'm sure everybody knows that, but I would urge you to. So when your doctor or your care provider says, Mrs. Jones, your hemoglobin A1C is 7.6, I don't want you to look at 7.6. So there's a correlation between testing the blood sugars and knowing where the hemoglobin A1C is. And believe me, if you pay attention, you'll know how to predict your hemoglobin A1C even before the doctor. That's the beauty here. You can tell your doctor, okay, I expect my hemoglobin A1C to be below 7%, because I know from my testing where I'm going. So that's great. That shows that we are on the ball and we are ahead of the game. So this is it's very, very critical. Now, in the United States, what we used to think before was the tighter the control, the better we are. However, that's not true. That's not true. What's true is that if we can get to a hemoglobin A1C of below 7%, we are doing a good job. So that should be our first goal. Now, of course, it's like the bell curve. So in the bell curve, you have the majority sitting in the middle, and then you have the outliers. So we always have outliers, and that's fine. And we need to look at people on the bell curve. Everybody cannot be right in the middle, and everybody cannot be on the right or the left. So that's the beauty about treating diabetes, and going along. And this is what I was talking about. So when I'm checking my blood sugars, right? So my mean post-meal, for example. So when we know it's going up after a meal, you know where you're going. We cannot do just fasting, as a lot of people do. You gotta check your 2 hours after a meal. And the recommendation is 2 hours after the biggest meal, whatever that is in the day. So what they'll tell us is, let me put it this way. So if I'm going to check my blood sugar, my hemoglobin A1C is stable, I don't need to check it every day, yes. But if I'm going to check it twice a week, one day I would check it fasting, and so Monday fasting, and Thursday, for example, I would check it 2 hours after a meal to know where I'm going. And if I'm falling somewhere here, I would know that. I would know that. Then I need to take those steps to revert it back to what is normal. So that's the key of this whole explanation here. And as you can see here, people whose hemoglobin A1C is 8 or 8.5, you see what they're doing here? And they're not doing well. So we would know automatically where we're going based on these numbers. So these are the goals should be individualized based on the duration of diabetes, age and life expectancy, comorbid conditions like high blood pressure and high cholesterol, heart disease, and we want to control all of them and go from there. Now, as we said, we want to be careful that we don't punish ourselves to very low numbers, because there's no known scientific medical advantage in being low. So if somebody, there's no study, for example, which shows that I'm going to do better at 6% than 6.5% once somebody has diabetes, right? There's no study like that. Which shows that benefit. So we want to be careful that we don't get down too much and develop hypoglycemia in the process. And we've seen that also in our inpatient population. For when you have patients admitted to the hospital, our goal was to get it down as low as possible, and we would see a lot of hypoglycemia, but that doesn't help us. So we have a general goal of below 180 on that component. Okay, so this is an interesting slide, and I wanted to just share that. It's food for thought. So everybody cannot be below 7%. So what happens? Okay, so I work very hard, and I try to get my hemoglobin A1C below 7%. But there'll always be this group which is on the right side of the bell curve, which will fall out and have it more than 7%. So these are people who have very labile and brittle diabetes. Even a little stress, even a little increase in carbohydrates or change of time, less activity will just shoot it up, boom, and they go very high. For people like that, they're also very susceptible to dropping fast also. So that's a difficult population. So in those difficult populations, and of course there are others too, but in those difficult populations, you cannot settle for 7% because it's not going to happen. So we aim for less than 8%. So those are those special groups. So I just wanted to make sure we talked about it. The goal is, no matter what a person's age is, we want to be as healthy as possible. I don't care what their age is, So it's doable. It's doable, and it's possible. In other words, definitely, no doubt about that. One of the things I wanted to bring to everybody's attention was, so what numbers? Again, this is lab. So what numbers are we looking at besides hemoglobin A1C, right? Okay, tell me, what other numbers do we think are important in diabetes? Sorry? Yeah, exactly. So now, we've gone away. Okay, so the prime area where we got all our information and which the world learned about it was from Massachusetts. So Framingham is the name of this little town. So almost everybody enrolled in Framingham more than 50 years ago. So that's where we got all our initial data, and it was really groundbreaking. So and we've matured a lot from Framingham. Okay, and one of the things we've learned is the most important component of bad cholesterol is the small pesky particle, that's what I call them, called low density lipoprotein, LDL. Now, what I want you all to do is you ask your doctor, what is my LDL, Mr. or Miss? The reason being, there's a dangerous nexus between diabetes, high blood pressure, and high cholesterol. These guys, the way I see them, they have only one job, and that job is to make us ill. So excuse me, I'm not going to let you do that. So let's work for ourselves, right? So this is where it's critical we understand these lab components. So that's the way I see them because I'm a pathologist. It's easy for me to do that. I used to run my lab actually when I trained. So you want, okay, so LDL is the number one most important pesky little particle. What should be the number? Take a guess. Take a wild guess. Okay, close. Getting hot. Yeah, thank you. Exactly. It should be below 100. Yeah, exactly. You got to do that. You got to do that. And there are some situations where, even though it's even around 100, you would still want to take a statin because statins, a statin is a class of cholesterol-lowering agents like Lipitor, Crestor. So they go to the liver and turn down the production of cholesterol, the bad cholesterol, right? They are pretty serious drugs. They're not simple drugs, but so is high cholesterol. It's a pretty serious condition where the LDL can cause a lot of havoc with diabetes. People can develop some major issues. I mean, I cannot repeat that more. It's very significant. So this is a very important component in treating diabetes. And we're looking at the numbers. So if your number is not less than 100, well, too bad. You got to do something about it, okay? And here are those guidelines. So you tell your doctor, my friend, let's work on that, okay? So general question is, who is a candidate for aspirin? Provided it's not contraindicated for us. So let's say I don't have an ulcer, and I'm not allergic to aspirin or Motrin. So when do I become a candidate, right? So it's very critical. One is people who have hypertension. Anybody who has hypertension automatically becomes a candidate for aspirin. The second is in diabetes. There are specific indications as to why aspirin should be used, and that's exactly what it shows here. Okay. Now, coming to our next important segment, we have blood vessels all over the body, right? Right from here down to our toe. And when there's high blood sugar, don't forget, the blood sugar is flowing all the way from here down to my toe, the tip of my toe. So every blood vessel is susceptible to damage from high blood sugar. So the key is the kidneys, when they get damaged in their lining called the basement membrane, then we start developing what is called kidney disease. So it's classified. It's phenomenally classified now, which we didn't 10 years before. And one of the most important ways of picking up kidney disease is by checking excretion of albumin or protein in the urine. How many of us know that our urine is being checked for protein or albumin? So it should be used as a screening test at least once a year, minimum, once a year. And there are different ways of doing it, but all methods are pretty accurate. So at least I would do it once a year. So once we do pick up an abnormality, for example, if you see on the slide here, normal is less than 30 microalb, and greater than 30 is positive, which means there's a leakage of microalbumin coming out from the kidneys when it shouldn't. And that is considered a very significant finding in anybody who has diabetes, with the danger of developing kidney disease down the line. Also, even though I haven't seen studies lately on this, there's a big concern amongst physicians that a microalbumin excretion beyond 30 leads to heart disease with diabetes. So that's a big concern we have. So in other words, it's just not a good idea not checking it. It's not a good idea not addressing it. So that's very important. So again, you write down that question when you go to your doctor. You say, hey, what's my microalbumin excretion? And I'm sure your doctor should be able to answer that. And just as an FYI, so this is, okay, I'm a pathologist, right? So I've done a lot of autopsies on people. And where I trained, we had a lot of people who had kidney disease. So I've done a lot of autopsies on people with kidney disease. And the reason I bring that up is, once you do an autopsy, the horse is out of the barn. So there's nothing we can do about it. But my greatest advice to all of us who have diabetes is here. And that is knowing that kidney disease is a significant component of diabetes. You want to make sure you're screened for kidney disease every year minimum, number one. And number two is you want to know from your doctor what is your kidney function. And that's exactly, it's called GFR. It's not a very technical term. It's a simple term. GFR means what is the flow from your kidneys in terms of functioning. It's a functional test. It's a phenomenal test. It's a very easy test. Everybody who has a blood test done for their kidney test, kidney function, we calculate GFR from that. So we have all the computers in the United States are automatically formatted in their software to calculate what is called eGFR, electronic GFR. Okay, so what happens is this is where the real danger comes in. So the kidneys slowly deteriorate in function as we all get older. So that's nothing new. That's nothing new. But what's dangerous is the layering effect of different conditions. So the two most important, if you walk into a hemodialysis unit and you have 10 people, if you ask them what condition you have, 90% are going to say two conditions first. Diabetes, hypertension. Okay, you're going to find the minority with lupus or one of those other conditions, which is pretty rare. So don't even think about it. But this is the critical part. So the question comes in, okay, why is this person getting dialysis, right? Okay, well, the person is getting dialysis most likely because their diabetes was not controlled well. You see, I had a 40-year-old gentleman who was on dialysis. That's ridiculous. That's absolutely ridiculous. But the reason it happened was the diabetes was totally out of control for 20 years. And then that's enough damage for the kidneys to say, bye-bye. Too bad. You've done a bad job. I'm going. So this is on dialysis, right? So luckily, the majority of people do not fall into that category. But the majority of people have a great concern behind them, which they may not know about. And that is when they get into this stage. So it's called stage 1 and stage 2. So what I want to know if I have diabetes is, what stage am I? Am I stage 1, stage 2, stage 3? Because as time goes on, we know we're going to lose kidney function, but you add diabetes to that and you add high blood pressure to that, it can be much faster. So it's very critical at least once a year to know what your eGFR is, okay? You gotta have a checklist, believe me. And you know what, doctors get this big form. I get this big form where every year I can fill out what the hemoglobin A1C is, what the albumin level is, LDL, eGFR. That's the checklist I want you to make. Okay? Because that's how you'll know. It's like, well, tell me, you're driving a car, right? We're not driving a plane, we're driving a car. And of course in your car, you need your speed gauge, speedometer, and you need your oil gauge, and you need this basic stuff. This is the basic stuff. If I'm not going to look at how fast I'm going, what am I doing? I'm not doing it right. Is that correct? That's what this dashboard is, what I'm talking about. So I want you to have that dashboard. I want you to look at every gauge, which is not a lot anyway, but you got to know where you're going. Otherwise, you're leaving it to luck or whatever. I don't know, but we don't want to do that. In today's world, that's not acceptable. That's what I'm saying. See, this is the recommendation where they say refer to a nephrologist when the function goes below 30. Well, excuse me, I'm not going to wait. No. It's a reasonable recommendation to me, but I don't agree with that. I refer my patients to a nephrologist when they are at stage 2. I don't even let them go to stage 3. And I tell the nephrologist, okay, pal, tell me, what can you do more besides what I'm doing right now? Well, they may not be able to do anything, but you have everything where it should be. You know where everybody stands, and that's very critical, right? How many of us know our EGFR? Tell me. So, not acceptable. Believe me. I mean, I'm not here to criticize, but this is not acceptable at all. So that's my request to you. Please do that. And, okay, so retinopathy. Again, I have a very close friend of mine who's my patient also. And I was very disappointed that he developed a little retinopathy, which is damage in the eye from diabetes. And it bothered me to no end, because we do a really good job keeping his blood pressure under control, blood sugar under control, and his blood pressure also good. But the thing is this, okay, all we can do is go for an yearly exam, because that makes sense from all the information, all the research we've done. It makes sense for us to go to an eye doctor once a year. But just because my hemoglobin A1C is 6.5 doesn't guarantee that my eye exam is going to be normal. So I have to prove that. And that's the key here. So we want to make sure we don't have retinopathy. And here's the foot diagram which I was raving about. And this is very critical. See, that little line is that monofilament. So that monofilament, and it's not done in any part of the foot. So we already know that underneath the first toe, that's where people first lose their sensation to that touch from the monofilament. So when your doctor examines your foot, you want to make sure those are the places it's touched. Okie dokie? So that's the place to go. And that's very critical. So I would definitely urge you to make a checklist of these things we talked about today, because it'll serve you well. Believe me, you may save your kidneys better than what you thought you wouldn't. That's where it is. And the greatest danger is in the eye and in the kidneys. It's very hard to reverse that. So if you're better off prevention, so prevention is better than, an ounce of prevention is better than a pound of cure. It holds for everything. You want to make sure you do everything to prevent any progression, which is possible from diabetes. Because, diabetes is, it's funny. One of my colleagues here when I was new, which is not that long back, okay? I'm kidding. He studied medicine at the University of Vienna. And he said, our society, their society in Vienna in those days, which was he was my dad's age, that was 1930s and probably 40s, was very syphilized, not civilized, syphilized, because syphilis was very rampant in Europe in those days. So the society was very syphilized. And that joke was meant to say that, syphilis as a disease affects almost every part of the body, including the brain. And so does diabetes. So diabetes is the new, or not so new, but the current leader in all these complications. So that's why we need to everything we can know about it and treat it well.